Welcome everyone. In this video we shall be talking about seminoma and discuss all the questions related to it. So moving on to the first question. So seminoma belongs to which group of testicular tumors? Right. Before we answer this question, let's have a look into the classification of our testicular tumors. Right. Now testicular tumors can be broadly classified into two groups. We have the germ cell tumors, we got the germ cell tumors, and we have the stromal tumors. Stromal tumors are also known as the sex cord tumors. Okay. Now these germ cell tumors can be of two types. We got seminomatous germ cell tumor and we got non-seminomatous germ cell tumor. Non-seminomatous germ cell tumor. The seminoma falls under this category. We have only one entity under that is one entity under seminomatous germ cell tumor, which is seminoma. Under non-seminomatous germ cell tumor, we got five things. We got embryonal carcinoma, we got yolk sac tumor, we got choriocarcinoma, we got teratoma, and we got mixed GCT, mixed germ cell tumor, right? We got a mixed germ cell tumor. Okay. Whereas under stromal tumors, we got only two types. We got the Leydig cell tumor, and we got Sertoli cell tumor. Okay. Now the question asked us about seminoma, so it would be a germ cell tumor. Answer should be option C. Another important option over here is the non-germ cell tumor. Non-germ cell tumor, usually we have the other specific varieties like lymphoma falls under this category. Okay. Moving on to the next question. Which of the following are germ cell tumors of the testis? We just discussed seminoma is a germ cell tumor. Yes. Embryonal carcinoma. Yes. It is a non-seminomatous type but a germ cell tumor. Yolk sac tumor. Yes. But Leydig cell tumor. No. Leydig cell tumor is a stromal tumor. Right. So our answer would be C. Okay. Moving on to the next question. Which of the following is not a recognized subtype of seminoma? Now there are three important subtypes of seminoma. Classical seminoma, yes. Anaplastic, yes. Spermatocytic, yes. But not syncytial, but not syncytial seminoma. Our answer should be D. Right. Before we move on to the next question, let's quickly have a look into these three things. Right. Classical seminoma is actually the most common subtype, accounting for around 60 to 70%. Right. Classical seminoma is associated with all markers, right? All the usual markers to be positive, especially PLAP, which is placental ALP, which is placental alkaline phosphatase. Right, all the classical features that we are going to study in this chapter will be regarding classical seminoma. If we look into the other two, if we talk about the anaplastic seminoma is characterized by high mitotic rate, and more pleomorphism. Right, as a result of which it is associated with a poor prognosis as compared to classical seminoma. Of course, high mitotic rate, more pleomorphism, it is a more aggressive tumor, so will be associated with a poor prognosis. Another important feature of anaplastic lymphoma is that there is less lymphocytic infiltration. One characteristic feature we can remember about classical seminoma is that there would be increased lymphocytic infiltration in its histopathology. We shall be talking about it a bit later, right? But in anaplastic seminoma, the lymphocytic infiltrate will be less. And if we talk about the other variety, just a second. Sorry. If we talk about the spermatocytic seminoma, right, it is seen in elderly patients. It is seen in elderly patients beyond 50 years. And another important thing is that it is PLAP negative, right? PLAP is a very characteristic marker for classical seminoma, but PLAP is negative over here. Another important thing in histopathology, we would see a very characteristic thing. We get three different types of cells on the basis of size, which are small, intermediate, and giant cells. We would get three different types of cells. Okay. These are the few important things, and is quite indolent, right? Not that aggressive. Okay. So moving on to the next question. Now, peak age incidence for classical seminoma, it is 30 to 40 years. So factual question. If we look into the other options, childhood, the most common testicular tumor would be a yolk sac tumor. Whereas in elderly, the most common tumor would be lymphoma. The most common tumor would be lymphoma. But if someone asks about the most common variant of seminoma, it would be the spermatocytic variant. It would be the spermatocytic seminoma. We just read about that. Okay. Moving on to the next question. Predisposing factors for seminoma. Predisposing factors for seminoma include cryptorchidism. Yes, cryptorchidism is rather the most important precipitating or predisposing factor for seminoma, right? Gonadal dysgenesis like Klinefelter's and Turner mosaic. Yes, this is a risk factor. It rather increases the risk of all GCTs, not only seminoma. Testicular dysgenesis syndrome. Yes. Family history of germ cell tumor is also a predisposing factor. So over here, our answer would be D. Right, now besides these, if we talk about the risk factors, there are a few more, right? Infertility is a risk factor. We have testicular atrophy, we got testicular atrophy. I'm so sorry, we got testicular atrophy, and remember that a testicular size of less than 12 ml is considered as testicular atrophy. Okay. And another important thing, if we get if a child gets a intrauterine estrogen exposure, okay, that is also a predisposing factor. Okay. Moving on to the next question. Which of the following cytogenetic abnormalities is characteristically seen in seminoma? Now this is again a factual question. Just remember the fact that isochromosome 12p is associated with seminoma. If we look into the other option, translocation 922 very well associated with CML. Deletion 13q14 is associated with retinoblastoma, whereas translocation 1418 is associated with follicular lymphoma, right? Just remember the fact that isochromosome 12p is associated with seminoma. Okay. Moving on to the next question. Now, seminoma is typically positive for which markers? The markers of seminoma. PLAP, we just discussed that PLAP is one of the most characteristic markers for classical seminoma. OCD4, yes. c-KIT is also a marker for seminoma, but cytokeratin is not. Cytokeratin is actually a marker for non-seminomatous GCTs. Non-seminomatous GCTs, cytokeratin would be a marker. Now, besides these three markers, if we talk about other markers, we would have beta HCG to be increased, beta HCG and LDH to be increased in seminoma, but they are extremely non-specific, right? So over here our answer would be C. Okay. Moving on to the next question. Identify the tumor, right? Now we can very well appreciate, so one gross image, another histopathological image. In the gross image, we can very well appreciate that we get a homogeneous fleshy lobulated appearance. You can very well appreciate the lobes, various lobes over here. We get a lobulated appearance. So this is classically described as the cut potato appearance. And few important things to remember over here is that in the gross section we do not get any hemorrhage, or necrosis, right? It is extremely homogeneous, right? No hemorrhage or necrosis is visible over here. Okay, now this is very much suggestive of seminoma. Now besides this gross image, we also have this histological finding where we can very well appreciate three different types of things. This is one area, this is also the similar area. This represents a clear cytoplasm, right? We get round cells with clear cytoplasm, right? Now this is characteristically described as the fried egg appearance, right? So this is also characteristic. This is also a very characteristic finding of seminoma. Besides these, we can also get this lymphocytic infiltrate. We discussed that classical seminoma is characterized by lymphocytic infiltration, and besides these two findings, you can very well appreciate this fibrous septa over here. This is the fibrous septa. These fibrous septa divides the lobules, right? Now these three histological findings along with this gross finding of cut potato appearance, everything suggests us of a seminoma, right? It is without doubt a seminoma, but we can very well rule out the other options as well. Embryonal carcinoma and choriocarcinoma. Now these two things are associated with hemorrhage and necrosis. Hemorrhage necrosis would be present, which is absent over here. Whereas yolk sac tumor would have a mucoid appearance, right, which is not appreciated over here. That's why your answer over here would be seminoma. ठीक. Moving on to the next question. Match the following with respect to the variants. We have read about the variants. PLAB positive, OCT positive, c-KIT positive. It suggests us of a classical seminoma. More mitosis, less lymphocytes is suggestive of anaplastic. More mitosis, less lymphocytes, poor prognosis. Older age, no PLAB, indolent, it would be spermatocytic and contains non-seminomatous elements, mixed seminoma. Okay, so it would be 1A, 2B, 3C, 4D. Option A should be our correct answer, right? We have discussed about this. Moving on to the next question. Now, a 32-year-old man presents with a painless testicular mass. Lab report shows that the AFP is normal, beta HCG is mildly elevated, LDH is high. USG shows a homogeneous hypoechoic mass. What is the most likely tumor? Now, this USG is the most important finding over here, that we get a homogeneous mass. This homogeneous finding in USG is very much suggestive of seminoma if we consider testicular tumors. Because the markers are not that much specific. This beta HCG and LDH are surely increased in seminoma, but not very much specific for seminoma. That's why we have to rely on USG for the diagnosis. But these markers can help us to rule out the other options. If we talk about embryonal carcinoma, over here your AFP would increase. But AFP in the given question is normal. Moreover, we get a heterogeneous finding, not a homogeneous finding. Why? Because of the necrosis and hemorrhage, as we discussed in the gross section earlier. Even in yolk sac tumor, also we would get very high AFP, but we get a normal AFP over here, so this can be also ruled out. Even choriocarcinoma, in choriocarcinoma we would get very high beta HCG levels, not mild elevation. Moreover, we would also get a heterogeneous finding. In choriocarcinoma. That's why our answer is seminoma. Okay. Moving on to the next question. The most common clinical presentation of seminoma, it is without doubt a painless testicular mass, right? It's a painless testicular mass. Almost all the tumors present like that. Painful scrotal swelling would be seen in a torsion, or an infection, or even in trauma. Gynecomastia in a testicular tumor would be associated with choriocarcinoma. Why? Because of the increased beta HCG. And scrotal ulceration is a very advanced disease, right? It's a very advanced disease, T4 disease. In seminoma we might get, in testicular tumors we might get scrotal ulceration, but it's not a very common finding. Okay. Moving on to the next question. Seminomas primarily spreads via, right? This is also a factual question. It spreads via lymphatic routes to the para-aortic nodes. Hematogenous route to liver very rarely might even go for a hematogenous spread, but it's extremely rare. Direct invasion through tunica vaginalis is not very much seen in seminoma. It is characteristic of advanced non-seminomatous GCTs. Right? And skip metastasis to lungs? No. So answer over here would be A, lymphatic spread to para-aortic nodes. Okay. Moving on to the next question. Now, seminoma is highly radiosensitive. Yes, that's a true statement. Highly chemosensitive. That's also a true statement. Remember that seminoma is both radiosensitive and chemosensitive. Both radiotherapy and chemotherapy are used for treatment of stage 2 and stage 3 seminoma, right? Associated with a good prognosis, usually classical seminoma, which is the most common variant, is associated with a good prognosis. There are certain variants, as I discussed, the anaplastic variant might have a poor prognosis, but usually on an average, seminoma is associated with a good prognosis. Okay. Usually bilateral, no, that's a false statement. Remember, for seminoma, the incidence of bilaterality is just 1 to 2%, right? And the most common bilateral testicular tumor is nothing but lymphoma. So over here our answer should be A, B and C. Okay. Moving on to the next question. A patient with a painless scrotal mass underwent a high inguinal orchidectomy. HPE confirmed it to be a seminoma. The lab values are given: LDH 6 times the upper limit of normal, HCG 20,000 milli international units per ml, and AFP of 5,000 nanograms per ml. which stage will you classify this seminoma? Now this this staging can be done with any one of those lab parameters. But all three of them can be done just for concordance, right? Now before answering this question, let's have a look into the staging. Let's have a look into the staging based on your LDH levels, on HCG levels and AFP levels, right? The units are similar to that mentioned in question. One is times the upper limit of normal, second is million international units per ml, and the third one is nanograms per ml. Okay. Stage 0, everything is normal. Everything is normal. Stage 1, stage 2 and stage 3. Right. Stage 1 is when LDH is less than 1.5 times normal. Stage 2 is 1.5 to 10 times normal. And stage 3 is more than 10 times normal. Right. Any one of them can be used for classification, but all three are done just for concordance, right? Just for confirmation. HCG less than 5,000 milli international units per ml. Right, 5,000 to 50,000, 5,000 to 50,000 and more than 50,000. AFP less than 1,000, 1,000 to 10,000 and more than 10,000 in stage 3. Okay. So if you look into the values, 6 times 20,000, 5,000, everything is suggestive of it being stage 2 seminoma. Okay. Moving on to the next question. A 32-year-old male with suspected seminoma underwent imaging for further evaluation. Imaging showed involvement of the epididymis and spermatic cord. Right, a lymph node measuring 3 centimeters in greatest dimension. No evidence of distance spread. What is the TNM staging? Right. Before answering this question, let's have a look into the TNM staging. First, T1. T1 is your involvement of testis and epididymis is present. Along with that, your tunica albuginea can be involved, but your tunica vaginalis remains uninvolved. Okay. If we talk about T2, yes, your testis and epididymis, your testis and epididymis is involved, your tunica albuginea is involved, and even your tunica vaginalis will be involved over here. Okay. In T3, spermatic cord will be involved. Whereas in T4, scrotum will be involved. Okay. So this is our T staging. Right. N staging is not dependent on number of nodes and not dependent on the site of nodes. It is actually dependent on the size of the nodes. Right. If the size is less than 2 centimeters, that is N1. If it is 2 to 5 centimeters, N2, and more than 5 centimeters, it is N3. And if we talk about M0 when the mets are absent, M1 when mets are present, right? And M1 is further divided into M1A and M1B. M1A means it spreads to the lungs or the non-regional lymph nodes whereas M1B means the other sites, any other site. Okay. Now let's move on to the question. No evidence of distance spread, it is M0. Lymph node measuring 3 cm, it would be N2 because it lies between 2 and 5. And there is involvement of epididymis and spermatic cord. Nothing has been mentioned about scrotum, so we would consider it to be a T3 tumor. So T3, N2, M0 should be our answer. Okay. Moving on to the next question. The management. Match the following. The scenario and the management. Now, just these 4 things that we need to remember. Stage 1 seminoma with normal tumor markers, the best thing to do is observation. For a stage 1 seminoma with normal tumor markers, the best thing to do is observation or surveillance. But as an alternative treatment, we can go for a single cycle platinum based chemo. As an alternative, but the standard regimen, the standard therapy would be observation or surveillance. Okay. Excuse me. Moving on to the next one, that is stage 1 seminoma with raised tumor markers. The best answer would be the single cycle platinum based chemotherapy. Okay. Next, stage 2 seminoma with positive nodes. Usually stage 2 and stage 3 seminomas are associated with positive nodes. So stage 2 seminoma with positive nodes, the best therapy is initial radiotherapy followed by chemotherapy. Okay. Usually chemotherapy is given when the radiotherapy fails or if there is a residual disease. Whereas in stage 3, we would start with chemotherapy. Now, if chemotherapy fails, or if there is residual disease, then we go for radiotherapy, right? Just remember that stage 2, we start with radiotherapy, then chemotherapy, and if it is stage 3, we start with chemotherapy, then go for radiotherapy, right? The chemotherapeutic regimen that we follow is the BEP regimen, which is bleomycin plus etoposide plus a platinum compound, cisplatin or carboplatin. Okay. This is our BEP regimen, and the chemotherapeutic regimen that we use in testicular tumors. So our answer over here would be 1D, 2B, 3A and 4C, which is option A. Okay. Moving on to the next question. Which features indicate poor prognosis in seminoma? So metastasis beyond retroperitoneal nodes. Metastasis beyond retroperitoneal nodes is M1A, and anything metastatic is associated with poor prognosis. So yes, it is associated with poor prognosis. Now, large tumor size more than 4 centimeters. Now, this large tumor size is associated with an increased risk of relapse. But it is not associated with a poor prognosis of the primary lesion, right? Yes, there is increased risk of relapse with a large tumor, but it does not indicate a poor prognosis in the primary tumor, right, for which you are being treated. So this is not an indicator of poor prognosis. Elevated LDH is a concordant finding for diagnosis, right? It is a marker of seminoma. But it is not a marker of risk stratification. It is not a marker of poor prognosis, right? An invasion into spermatic cord. Shows that it is a T3 lesion. Yes, it is locally a large tumor. It has involved your spermatic cord, but again, it is not associated with poor prognosis. Right? So our answer over here would be only A, right? Only A would be the best answer, and had only A been not there, then our best answer would have been A and B, right? But if only A is there, then our best answer is option A only. Okay. Moving on to the next question. Before we move on to the next question, remember that indication of poor prognosis, this is the only thing which indicates poor prognosis. Metastasis beyond retroperitoneal node in a seminoma. Okay. Moving on to the next question. A 60-year-old male presents with a slow growing testicular mass. Microscopy shows 3 types of cells: small, intermediate, giant. No lymphocytic infiltration, no PLAP expression. It would be was. I'm so sorry. It's found on IHC. What is the diagnosis? Without doubt, everything over here is suggestive of spermatocytic seminoma. It is an elderly patient. Slow growing testicular mass. It is indolent. It is PLAP negative. 3 types of cells on histopathology. Decreased lymphocytic infiltration. Everything about spermatocytic seminoma has been mentioned in the question. It is without doubt spermatocytic seminoma. Okay. With this, we come to the end of our discussion on seminoma. If you like this video, consider subscribing to my channel, and thank you for watching.